Okay, can you hear me now? What I'm going to do is we're going to go through this first section, and then this afternoon, which it may spill over to this afternoon. But this is more important because this afternoon should go pretty fast because it's really at the mechanics of this. You know, some longitudinal charts and I'm specific look at the anterior lateral distribution, and so this stuff you can grasp right away. This stuff is a little tedious. Okay. So the anatomical substrates of needling is, of course, those local fine vessels with these sequestered mast cells. Slightly deeper veins that force the egress of the immune cells at the needling site. Afferent substance feeds nociceptive pain fibers that mediate needling response and sustains the needling reaction by axon reflex. Remember a little circuit that goes from the point and then back to the capillary bed under the point. Then the static load spindles, which are in the muscles. These are muscle sensory control sensors. The static load fibers needed to provoke propagated sensation. If you don't have these fibers, you can't get any propagated sensation. And a lot of times with musculoskeletal problems that people have, some that you can cure with one treatment, they have a problem with their muscle spindle circuits are not working well. Spindle is affected by local temperature and pressure and can influence propagated sensation. If the temperature, if the atmospheric pressure is high, you get a lower incidence of propagated sensation. If it's low, you get a higher incidence. If the temperatures are warmer, you get a higher incidence than if it's cold. So these just the external effects that will influence the system. Of course, the big thing is autonomic nervous system participation. Mainly initially is the sympathetic nervous system with afferent and efferent fibers of the local blood vessels. Parasympathetic fibers activated by needling, but there are no parasympathetic nerve fibers in extremities. For example, you can needle Jus and Lee on the leg, and you can measure a sympathetic fiber response in those nerves, but you also get a parasympathetic response in the vagal nerve. So this connection is not the peripheral nerve. There's no peripheral nerves, parasympathetic fibers in the extremities. So there's no fibers out there. But when the signal comes into the spinal cord, that's where it picks up the parasympathetic signal that goes into the vagal nerve, that stimulates the vagal nerve. That's where it comes from. So all these organs have input from the vagus nerve, these parasympathetic fibers. And so between the sympathetic and the parasympathetic activation, this restores visceral homeostasis. Now you got a balance between parasympathetic and sympathetic. Yeah, they've done, China's done numerous experiments where you needle Jus and Lee or some other extremity point or point on the extremity, and they can measure response in the vagus nerve. Oh, there's no vagal nerves in the extremities. Huh?
What's happening in the brainstem, or
No, it's
the descending control feedback?
No, it's happening because all these organs have parasympathetic innervation. So when you stimulate the sympathetic, it fires it off, although there's not a nerve in the extremity. So you get every time you needle, you get a response in the vagal nerve.
So this is the descending control of the parasympathetic.
No, the descending control is neither. It's the serotonergic nerves enkephalins, shutting it off. So it shuts off the nerves. And so by doing sympathetic, parasympathetic, when you're finished, then you have true homeostasis, so you're balanced again. But you can search all the others. No parasympathetic fibers in the extremities. So the Chinese have done all this research already. I'm the only guy that read it. Well, the only American. Okay, so sympathetic nerves normalization restores blood flow, and both sympathetic nerve and parasympathetic nerves participate to restore visceral homeostasis. Now, this is important because a lot of problems we're treating involve visceral problems. And so you get everything. You get pain control, you get all this restoration, which is fantastic. And as far as the central nervous system, these nerves are from the brain, and they synapse on the dorsolateral funiculus and cross anterior lateral tract fibers. Oh, yes, these are the afferent nociceptive fibers synapse on the dorsal horn when they go to the spinal cord and also go up the anterior lateral tract. So you get signals going up the dorsolateral funiculus on the same side that you're needling, and you get the other signals going up the anterior lateral on the opposite side. But when it gets up to the brain, it switches over. But that's how that thing works. And then the anterior lateral tract, it's not just one tract, it's the spinal thalamic, the spinal reticular, and the spinal encephalic tracts. So you're sending signals to all three of these brain areas, and they're doing different things in processing the signal and descending and giving you descending control. And most of that descending control comes through the spinal reticular tracts. Information processing mainly in the brain stem, and then it sends a descending control signal down to the area of where the needling signal comes in, otherwise the area where you've told the body to send the needle signal to, the restorative. By your point selection, you're telling the body where to send the restorative process. It's almost a no-brainer, yeah.
So with a degenerative brain condition, Alzheimer's, dementia, does that reduce the effects of acupuncture because it's brainstem or brain control?
Some conditions of stroke. Some stroke patients, you can treat them and they recover. Some don't respond at all because there's damage in the brain. And Alzheimer's also is a problem as a lot of circuits aren't connected anymore. So this thing is called the spinal afferent processing system. It transmits needle-induced somatic nociceptive and proprioceptive, remember proprioceptive system, afferent signals to stimulate the higher levels of the central nervous system. Then it directs the descending control to inhibit nociceptive fibers plus somatic and autonomic motor fibers over the same spinal cord range that you inserted the needles. You put them in the leg and somewhere else, but where do they integrate into the spine? That's where the descending control comes to. So initial pain fibers, it inhibits pain fibers, restores autonomic nervous system balance, normalizes vascular and visceral tone, relaxes muscular tissue over range of needling insertion. Then what else we get? Also provides descending control regions of the spinal cord that mediate inhibition of pain, relaxation of muscle tissue, normalization of vascular tone, restoration of visceral homeostasis. That's kind of a repeat. So here's the key. Descending control process is directed by you, the practitioner, to obtain the desired clinical effects. Okay, well, the main benefit of needling is restore proprioceptive and motor functions through these reflexes by direct influence on the motor nerves. restores flow of nutrients, ing, oxygen from air, qi, defense substance wei, substance of vitality, hormones, and blood flow in muscles to muscle organs to normalize the sympathetic nervous signals. So the role of these nodes, they exist at these collateral branches of the longitudinal distribution vessels, contain high concentration of sensory fibers, fine blood vessels, lymphatic vessels, and mast cells. Anatomical and histological properties make these nodes more responsive to minute tissue damage. And so the Chinese were the first to note that the skin has a primary defensive role. Body evolved different efficient defenses against pricking, pathogenic assault, insect bites, etc. I mentioned that earlier. It involves many factors of blood coagulation system. Let me see here. I'm going to have to sit down here for a while. So how are we doing on time here? Okay. Let me see. Where is it? Important mediators include substance P. These are neurokinin 1 receptors, bradykinin B1 and 2 receptors, and cytokines. Nodal sites contain high concentration of the fine vessels, nerve fibers, and mast cells. Needle insertion causes a visible immune reaction, flare response around the needle. You all know that. Flare inhibited by capsaicin that depletes substance P by interrupting the nerve, which was verified by Lewis in 1935. Mediators include mast cell histamine, platelet activating factor, leukotrienes plus substance P itself. Inserting a needle or any other object that pierces skin causes this tissue trauma. Incidental trauma by needle results in tissue and capillary damage products. This includes collagen, microfibrils, fragments of the basement membrane. Any of these things floating in the body, in the blood, will trigger the Hagman factor 12. And then certain proteins, zymogens, these blood coagulation factors, that continually circulate in the blood just looking for problems that might arise. Most are produced in the liver and are responsible for keeping the blood flowing smoothly in the vascular system. Otherwise, it's always a struggle between coagulation and solubility. So it's balanced really careful. Otherwise, you're going to die either way. Always balance between clotting for vessel repair and maintaining solubility. Balance of clotting versus hemorrhaging. Needle damage products activate Hagman factor, I mentioned this earlier, from 12 to 12A, meaning activated. 12A stimulates, activates kinin, fibrinogen, and coagulation features of this system, which I have a little diagram here. Causes localized immune defense to needle involving vasodilatation, immune cell egress into the damaged site, and firing off the pain fiber. Okay, here's a little diagram. Is this in your chart?
Yes.
So here's the needle insertion. You dange it into the small blood capillaries, blood vessels and capillaries. Produces collagen, microfibrils, and basement membrane. These are tissue damage products. And this activates Hagman factor 12. This is one of the plasmin and tissue zymogens. So you get 12A, and then 12A by 3 different cascading responses. One being producing plasmin from plasminogen, which then activates the immune complement 3 C3 alternative pathway. And then prothrombin gets inhibited by the heparin from the mast cell. So temporarily this is inhibited, so you don't get blood clotting. But then kallikrein is produced, and a plasmin kininogen then is activated, producing bradykinin. And bradykinin excites the nociceptive nerve, and it promotes vasodilatation and smooth muscle contraction. So this is how all this stuff boils down to. Okay. What's it? Oh, not okay. Yeah. Basic defense mechanism uses at least 30 proteins circulating in the blood. Named complement because system helps antibody kill invaders. Well, this is a complement. Marks any cell that does not have a certain protective protein coding. However, it has an alternative pathway. It's activated by needling or minute tissue damage. And this wasn't discovered until the mid-30s, because they always thought, well, the complement system, there's only one. But if you do tissue damage, you can directly trigger the C3 immune complement, which I'll show you a little diagram here. So here's the diagram of, here you have an antigen attacking a cell or something, and an antibody complex, and then C1 comes in to make this work. In other words, without the C1, that doesn't work. So that's why people called it a complement. It was complementing the immune response. And then it goes through to C1 to 2 and 4, and an enzyme eventually to C3. Then C3 has an amplification loop, an unstable feed-forward amplification loop, amplifies the response by 1,000,000 to 1 or something. So you get this little tissue damage, and all of a sudden the immune response is amplified. So you get a big response in the body. Then C5, 6, 7, and 8, and 9, then what they do, this is the same location, but just showing, then it lyses this bad guy here, and it's done. So everything's back to normal. So what we're doing with needling is triggering this level. There's no antibody, there's no antigen. It's just tissue damage that triggers it. Because no one figured out, well, tissue damage can't do anything, but they forgot. They're always thinking about this. They're not thinking of, and this is what Sir Lewis discovered. Now, the alternative pathway is activated by blood coagulation response to tissue damage. I've repeated this about 1,000 times today, sorry. Does not require antibody, interacts with the blood coagulation to amplify. It will actually amplify this reaction, like this loop that produces more C3. This is what's called a feed-forward unstable loop. You get a tremendous amplification of this little bitty tissue damage. All of a sudden at the tissue level, it's amplified by an enormous amount.
Cause more tissue damage would that increase the production of C3?
Actually, it could, but it's amplifying the immune response. So you got this little damage, you get a little response, but now you get. Did you ever get talking somewhere where you're talking in the mic and it gets near a speaker, and you get this big, this loud sound? That's unstable feed forward. To give you an idea, it goes from that little bitty sound to this enormous sound. And so it's amplifying this immune response. So we don't just get a little effect, it's a staggering effect. And then by us selecting where we want these points to be stimulated, then is the key to how you take advantage of this to fix whatever problem you're trying to address. Yeah.
There's a possibility that if we stimulated too much,
There's a possibility that if we stimulated too much, we would have a damaging effect, obviously to the local tissue, which wouldn't satisfy the therapeutic effects we're talking about here.
Yeah, this is true in the case I told you where I had an anaphylactic shock to a antibiotic shot. That's what you get there. You get this thing totally out of control, and you get and usually it kills people. A few people survive that, so I was fortunate, or maybe I was unfortunate. I don't know, but with the tissue damage, it's different because you are activating the normal response. So he's not injecting penicillin in there. You do, and some people do. And then, of course, I reacted with anaphylactic shock. But with the needle, there's nothing in there. So this is just following this normal pre-established events of happening.
what would happen if you stimulated too long?
Yeah, you stimulate it too long, like you leave the needles in too long, and people do that. Then what it does, it just shuts down the system. It'll shut down. Usually the error we make is not stimulating the point strong enough for some conditions and not leaving the needle in long enough for some conditions. I mean, so these are things we control. We control how much tissue trauma we're doing. We can control how long we leave the needles in, the depth of insertion, all that. And then how do you stimulate the needles later? A lot of times we go in and we tweak the needles, for a lot of pain problems. But when you have urticaria, you don't touch the needles after they're stuck in. So it's just a matter of, if you understand, get a good comprehension of this, you're in control of it. Every practitioner's in control of what you're doing. And unfortunately, the schools didn't give you the tools that knew you were in control. So that's why we got a lot of people having fantastic success and people not having. And these are just little subtleties of how the body actually responds to tissue damage. No, but that was a good question. That was because no one has ever got an anaphylactic shock from a needle. That I can assure you. Now here's a little diagram of this feed-forward loop that once you produce C3, then it produces C3b with some other stuff, and then C3BB with this factor, and then this, called C3 transferase, produces more C3. Now it's producing it physiologically from these other substances, but it's still, there's converting other stuff in the body to more C3. So this is a feed-forward unstable control loop. So you get an enormous, it's just like the mic in front of the speaker. It's an enormous, so this is where the medical doctors just, oh no, it doesn't, but I have to show them. I worked at UCLA for a couple of years in the East-West Clinic, but I didn't make much headway. But this belongs to us, needle therapists. This is what we do. We need to know this system. This is our medicine. This is the key part of our medicine. Not to diminish selection of points, how long you leave the needle insertion, and all that stuff, and of course assessment of the problem. And so once you know this is real medicine. And I always like to rub it in to the MDs. Also, I participated in an acupuncture research program at UCLA Dental School. But they wouldn't put my name on the paper other than that. There was two studies. One was at Maryland, University of Maryland, and at UCLA. And it was a post-wisdom tooth extraction thing. I wanted to do the needling for the extraction. Oh, no, that would ruin our business if you could do that. So I can only do the post-operative. And then we did finding who got better, how long was their postoperative pain. And those that got acupuncture didn't have any. So we had placebo needling where we didn't actually put the needle in, we just taped it on the body. But they were blindfolded, they didn't know if, then I had an electrical machine I would turn on and it's blinking, and so they thought they were getting I only had one of the placebo one came in, a young woman. She said, is there any way I can get another one of those treatments? And I said, well, I can see if we can do it. She says, I want to tell you, I never felt so wonderful in my life after that treatment. And I thought, oh, I remember she's one of the placebo groups. So I don't know if that was my persona or my patient skills or what. But actually, I did give her a treatment, but I gave her a real treatment the second time. But that's how it goes. So this is our medicine. Okay, a complement, plasmin C3 provokes immune complement system. You already know that. C3 and 5 can also cause potent vasodilatation, degranulation of mast cells, and attraction of plasma basophils. And they also release heparin that inhibits the thrombin initially. Here's another simplified diagram of the two, which just simply shows needling causes tissue trauma, activates Hagman factor 12, affects the blood coagulation system, in particular, excites the nociceptive nerve, and that it sets off the reaction. Now, you needle people, you know how quickly something you put in a needle? Some people they'll feel a reaction right away. Just to show you, this is not a slow process. This is a very fast-acting reaction. And then the bradykinin also is a potent local vasodilator. We're squirting the bradykinin on the capillary bed below the acupuncture node. Then we got the C3. C3 gets amplified, so you get more C3. So by this time you get a very potent amplification of this little bitty tissue trauma. Then we take advantage of it, and then kinoprotease from the mast cells plus histamine and heparin goes back here and triggers this system more. So this is another feed-forward unstable loop that amplifies the response. So these things are working together. So little bitty needle, you get this fantastic response. As far as tissue goes, because tissue reacts to occupying a very small space in the tissue. So this is potent. So this is what we do. We take advantage of this. That's my cell phone, sorry. It won't change it. Okay, so complement alternative pathway, the alternative, it releases kinoprotease, the release kinoprotease stimulates production of more C3. This is the amplification part. Neutrophilic and eosinophilic chemotactic factors anaphylaxis. Big words there. Now called NCFA, and actually it was, Lewis gave these names to it. So eosinophils come in, and they are usually thought of as being specific for parasites in the gut, but they also have a very, very important role in these particular factors here, namely these two highly inflammatory reactions. So these attract these neutrophils and the eosinophils to the damaged site, and neutrophils are the plasma equivalent of the mast cell. So they're going to degranulate more histamine and all that stuff, but the eosinophils will have a different role, which I'll get into in a minute. So the mast cells, these are in the fixed tissue. I already mentioned that. Okay, and heparin statically bond to histamine, which is degranulated by the actions of immune complement C3A and 5A and 4A. So you get a lot of pathways for doing this. And selected phospholipids from the cell membrane of those mast cells, because we damage the mast cells that are stuck on the vessels, because we're damaging those vessels too. And this arachidonic acid, these phospholipids produce arachidonic acid. I don't know if you know what arachidonic acid is, but it's essential to life. And it will form leukotrienes and prostaglandins. Okay, I hope I didn't lose you here. More about this, I got another figure which is in your handout. So also enters the tissue and releases cytokines and proteins. Otherwise, these are more inflammatory agents. And they don't even know how many of them they are, but there's interleukin 1, 2, 3, 4, 17, and a lot of other things that somehow mediate all these cell relationships in response to the amplification or response to the immune system. So that's still being figured out. That's all the best I can say about it. Nobody really knows what they're doing yet. But it's even more complicated, but actually you probably don't even want to know. It's just if you know this much, you'll be a great practitioner. So these basophils are almost identical to the mast cells, except they're floating the bloodstream. So they come in to amplify the mast cell initiated reaction. They also participate in immediate type hypersensitivity, range from mild urticaria, some of your patients come in, rhinitis, and the problem I have from penicillin, severe anaphylactic shock, which is usually fatal. Now, the eosinophils, now these are really critical. And the reason is they have something to getting rid of those leukotrienes. You need these eosinophils. Now, these are abundant in the gut, the gastrointestinal tract, to defend against parasites. And usually when you talk to a doc about eosinophils, they'll say, oh yeah, this is parasites. But they have another very critical relationship in the blood coagulation and pain control system, which you're about to hear about here. They, so their normal role is fighting viral infections and capable of killing off invading organisms. Circulating eosinophils increased also in allergic reactions. But these are slightly different. They usually include asthma, other respiratory diseases, and gastrointestinal diseases. So when we have the hypersensitivity reaction, now here's another type of inflammatory or allergic reactions. Now platelets, these are the smallest corpuscular components of the body, only going to have a life of about 4 to 8 days. The cytoplasm contains actin, myosin, glycogen, lysosomes, and 2 types of granules, including serotonin, which is one of our transmitters for shutting off the pain. Aggregation fostered by platelet activating factor, secreted by neutrophils, monocytes, and platelets themselves. So you cause this tissue damage, so the platelets want to come in and plug up the hole eventually, but in the meantime, we get, let me stand over, get a look at this. They should have enlarged this table, did they?
Okay.
They did, oh, okay, good. This is the key to all acupuncture. So this is something you really should be familiar with. Remember, the mast cells, the basophils, the tissue damage of the mast cells, it produces these selected phospholipids. And then by an enzymatic process, they're converted to arachidonic acid. And there is a type of drug that is used here. These are Can I read that? Steroids. These are steroids. Blocked by steroid anti-inflammatory drugs. That blocks the arachidonic acid, so that's how they get rid of inflammation. Okay. Then we have the arachidonic acid that produces cyclooxygenase, and then that is selective, non-selective, is blocked by selective, non-selective non-steroidal agents. And then we have 5-lipoxygenase, and they just call it 5-LOX now, I think, or something like that. And it produces leukotrienes. These are these highly inflammatory. Leukotriene 4, 4, it's 100 to 1,000 times greater than histamine in producing inflammation. These are potent things. You find these, some of them are 100 times. You find these in rheumatoid arthritis. These. Now, how do you get rid of them? You get rid of them by the fact that the aryl sulfatase from the eosinophils you attracted by needling release, aryl sulfatase in those cells is released, and they eliminate these leukotrienes. Now, sometimes this requires leaving the needles in longer, because this is probably rheumatoid arthritis is tough. And then with the prostaglandins, they do some other things. One is they cause a degranulation of platelets, PGI2. Now, why do you need to do that? When you cause that little cell damage, vessel damage to the needling, there's a hole. But you don't want the platelets getting on there and blocking it up again. So for some period of time, this PGI2 will keep the platelets from jumping onto the hole and putting in a patch. Because the normal thing is it wants to patch that hole. But right now we need a needle to work for a while, so we patch the hole during the control phase. So we allow all the stuff to keep coming into the area where you needled. Okay. Now what do the other ones do? Well, it also produces thromboxanes AN2, which we need for blood coagulation and homeostasis, restoring homeostasis. So one is a potent vasoconstrictor. Another one here is a potent vasodilatator, preferable in the human lung. And this is another bronchial and vasodilatory regulate tissue microenvironment. So these things are essential to normal life, the prostaglandins. So now here you go, is putting a needle in a body, damaging some cells, microscopic cells, right? And it's producing these products of the cell membrane, produce arachidonic acid, and it does all this stuff. Amazing, huh? Yeah.
Can any of these processes you're describing be achieved with acupressure?
Oh, okay, the question was, do any of these things get activated by acupressure? And the quick answer is yes. There are some conditions where pressure alone will fix some problems. But you don't get these immediate tissue reaction type things, all this product sample. So you don't get as big of a bang. But with the needling, it's precision. The needle is right there. You're doing precision surgery on these locations. And that's the beauty of needling therapy. You, the practitioner, you control it. Yeah.
Wasa and cupping will also produce.
Cupping.
Yeah.
Cupping is also, in fact, I had a special set of low back pain cups made for me in China. I've been to China a few times. And in some cases, those cups alone, and they were about that big round cups, and they would neatly fit on the low back like that. I mean, that's what they were designed for. And someone stole them from me because I had some acupuncture students that came to intern with me, and somehow they disappeared. And I don't know who got them. And I could never duplicate them because I'd have to find that guy in China that made them for me. Yeah, pressure cupping. Now you get, what do? You have blood coagulation or blood circulation impaired in the low back. A lot due to spasms, cramps, blood cannot flow, right? So you put a big cup on there, or some of them, I've seen them cupping, using cups, long cups, lightweight cups, but for facial paralysis. You ever see that? For facial paralysis, incredible. So in the low back, you use that cupping. Now it brings up that tissue. Now the blood flow is restored to the area in the low back. Now you're definitely going to get a recovery. So you do that in conjunction with the treatment. You can do it before the treatment, preferably, and then it's going to enhance. So cupping is also, in fact, cupping, of all the things that's in our scope of practice, cupping's one of them. Needling is one of them. Electroneedling is one of them. And moxie busting is one of them. That's all that's in our scope. Nothing else. Regardless of what people tell you, that's all that's in our scope of practice. Dr. Previo will confirm that, right? So I use anything that's going to, or other, you use a whole range of things you can. And also you have to use herbs and things like that too. And a lot of times you have to pay attention to nutrition in some patients. So anyway, I got a good grasp of this, that little bit of kneeling, this fantastic response that you're generating, not just anywhere, but focused on the pathology.
For the autoimmune disease, so you mean
Put it closer.
for the autoimmune disease, so you will leave the needles longer
I can't hear you.
for autoimmune disease.
What was that?
For autoimmune disease.
Emergency usually needling?
No, autoimmune disease.
Oh, autoimmune. Oh, okay. Oh, excuse me. Yeah, autoimmune, obviously, it's pretty clear a lot of these things are related to autoimmune diseases. So you'll find that if you can produce this reaction, now keep in mind, this reaction is not causing a major catastrophe to the body. This is microscopic. Yeah, so some autoimmune diseases, well, rheumatoid arthritis, considered autoimmune disorder.
She was asking, do you leave the needles in longer
Yeah,
for autoimmune disease?
yeah, some of them. I had cases of systemic lupus. In fact, the most famous case I ever had on systemic lupus, I know Ted's treated some of this too. A patient of mine had this friend who was terminally ill with lupus. And she asked if I would treat her. Now there's a lady, she's given 3 more weeks to live. And I wanted to say, well, look, I don't think I get it. So I said, well, I'll take a look at her. So she lived in San Bernardino. So she went out and got her in a station wagon because she couldn't ride sitting up. She had to be laying down. That's how bad brought her to the back door. We wheeled her into the clinic, laid her down, and her arms were purple from the fingertips to the elbows, both arms. And I know Ted's had cases like that too. And I just had to tell her, I said, look at, and the other thing, she was trying to get pregnant when she came down with this affliction. And I said, look, I don't want to discourage you, but, and I didn't charge her. I said, but I'll do some treatments on you and see what we can do. So I did some treatments on her. And after the first treatment, the purple went away. It's gone. After the third treatment, the other problems went away. And I think she had maybe 2 or 3 more treatments. And, but she didn't die. So she went back to the doctor and said, I feel fantastic. I went to this acupuncturist. You went to an acupuncturist? You lost your mind? Says, but I don't have the problem. No. You're, so they did all the tests again. They said, oh, you don't have systemic lupus anymore. We must have misdiagnosed the case. But I have to tell you the other part of the story. This woman, my patient that brought her down there, she ran into her friend one day, and she did. She got pregnant and had a baby. And she said, aren't you thankful that I took you to see Dr. Kendall and he fixed you and you had your baby and all? And she says, oh no, God cured me. And so the woman calls me up, I'm so upset. She said, God cured me. And I said, I don't have any problem with that answer. I mean, who knows? Because this is godly stuff. That's what we're doing. Okay.